presenters from our second half of our talk.
See, they're orthopedic surgeons. They can bring up their own chairs. I'm not strong enough to do that.
Okay.
Thank you. Clicker's right there.
So, we have about 10-15 minutes. We're going to shorten our roundtable up a little bit because we're running a little behind. But for 10 or 15 minutes, opportunity to pick some minds on some discussion of pelvis, groin, and hip injuries or issues. I'll get us started with the first question, which I think Dr. Boyarsky addressed and Dr. Gatt kind of talked about a little bit too. But it's also something that's been published by multiple authors in the literature with an incidence rate of 12 to 94% of patients reported in the literature that note a significant incidence of both pubalgia and functional acetabular impingement together. So they're finding that the two are kind of running hand in hand. And I guess my question is, what's your experience with finding athletes who have experienced both FAI and pubalgia? And does one precede the other? Are they related in some sort of way? Is there some sort of compensatory motion that plays into it? Just kind of your thoughts on the duality of FAI and pubalgia.
I don't think they exist together. I think that I'm very skeptical of patients who come in and the orthopedic surgeon has either scoped their hips. A lot of them are coming into me now more and more with scars on their hips from having an operation done on their hips. I think it's unusual. I think that a 94% is, to me, absolutely not possible. To the point where it just is not possible. The nerve supply in the hip, groin, pelvis is so rich that it's referred pain is very common. But if you're looking for a specific athlete hernia, I do not think that patients who have true femoral acetabular impingement or labral tears actually have sports hernias. I've only done a couple. The last one I did, who had scars on his hips, it was not a happy outcome.
I agree with Andy. I think a lot of it is that it goes back to what we both talked about, is that history and physical examination, at least in our hands, are the two most important points that we address. If you look at even the manuscript that Eric is talking about in the papers, they're saying that based on radiographic criteria, the patients with sports hernia have radiographic evidence of FAI, but how many of them are symptomatic? And we recently had a case like this where we had a field hockey player who we were struggling with adductor tendonitis. She ended up going to Philadelphia and ended up having sports hernia surgery. But at the time of booking the surgery, she was asked if she was told that she should have a hip scope at the same time. We probably treated her for literally a year. She never had any symptoms consistent with FAI, but it was more that get the FAI surgery as a preventative measure, which I think is, at this stage of the game, there's no evidence to support that whatsoever. But I think the problem is we're not using a clinical diagnosis. We're using a radiographic diagnosis, and that's always dangerous.
The other part of it to me that's dangerous is that, and there's no delicate way of saying this, if you go to Philadelphia, you're going to get an operation. If you come to Old Bridge, I probably will operate on way less than 50% of the patients that I see. And that makes me very, very uncomfortable for that. I think I let that speak for itself.
One additional thing, I think in the literature, that number 94%, in the literature there's some confusing terminology regarding sports hernias, sportsman's hernia, athletic pubalgia, osteitis pubis, Gilmore's groin. And so if you are those all the same? Maybe, maybe not. There are some traumatic injuries that may not be a sports hernia, but fall into that category when you do your lit search. So that becomes very confusing and probably contributes to some of those numbers.
And I think part of it may play into it is, in terms of defining what it really is, there's still some ambiguity in what are we really dealing with in some ways too, right?
Absolutely, absolutely.
Questions? Yes.
You were talking about you see a difference in the external range. Do you think that's congenital or it is adaptive to what's going on? And if you think it's congenital, does that play into a direct split hernia?
I think that is acquired. I think it's acquired. And one thing, I'm glad that you brought that up. When you look at these external, when you open the patient up to fix them, their external oblique is absolute at the external oblique aponeurosis. You don't see the external oblique muscle when you do a groin operation. The external oblique is way far more lateral than where I am. I see the aponeurosis, or the tendon, if you will, of the external oblique musculature. It's absolutely abnormal. An aponeurosis, which is a tendon, okay, is a white structure, and this aponeurosis has these nice lines in it, okay, very nice lines that you see. In these kids with sports hernia, almost every one of them, those white lines are splayed open, okay, and they're pink. It's pink. Some of them splayed open to the point where it's almost tissue paper thin. I think that goes along with my theory of what's going on here. I think that there is some bulging that's going on underneath it, and it's splaying open those lines. It's an acquired problem. It's not congenital.
Yes.
For Dr. Gatt, with FAI, is that something that's genetic or?
Is it a genetic or like developed or both, like that you see?
It's definitely both. I mean, there are kids that are, I was seeing even with adults, or people who have a cam lesion on their femoral head. They've had it their whole life, and some of that's acquired. The theory is that, you know, there's the most severe case of a hip deformity in a kid would be a slip capital femoral epiphysis, where their growth plate slips. So one of the theories is that these are very minor slips that never really become clinically significant, but it leads to a misshapen femoral head. And then there's other now, and then what we're finding is that there is definitely an element of acquired cam deformity because of maybe some of the early participation in the at-risk sports. So it's both.
What about in the insert on the lateral side?
That would be the same. It's probably the same thing. That really hasn't been studied enough to give you a good answer to the question. It's always been focused on the cam deformity.
Mr. Mike's up.
From an online attendee, I've had 4 male and female youth soccer players who have very poor outcomes from Dr. Matt. Now,
So the question is visiting another surgeon with 4 soccer players who didn't have good outcomes, now what do you do with these athletes who are still having problems?
Well, I see some of these patients, okay. You know, no, I'm not sitting here telling you that Dr. Boyarsky does a perfect job every time, okay? Please don't get that feeling. I just don't understand what goes on down there in Philadelphia. I see them. I'd be happy to see them and reevaluate them, do an ultrasound. I've operated on a few of them, and with good results. I wouldn't say excellent results, but I'd say good results. Got them back on the field. But it's a real problem. It's hard to understand what he does. That's my problem. That's not just my problem. It's everybody's problem who deals with this. You can't understand what he's moved around, even the theory of this. It's very difficult to understand. I'm sure in his mind he has it down, and you know, a lot of his patients get better. I'm not saying that none of them get better. A lot of his patients get better. Tom Brady was back on the football field. You know, he did okay, even though he stunk up the joint of the Super Bowl. But you know, a lot of his patients get better. But I do see a group of patients, and that one of the things that, you know, that some of the trainers, especially at Rutgers, Princeton, and some of the other, you know, they once they saw what I did compared to what they saw coming out of Philadelphia, that's how I got into this a little bit more. But It's a difficult problem once you've been operated on once. But I will see these patients and try and help them out with it.
Other questions?
See, there's a lot of different operations described for athlete hernia. How many operations are there described for appendicitis? One, you take out the appendix. How many operations are described for cholecystitis, gallbladder? One, you take out the gallbladder. How many operations are there described for athlete hernia? Up to 10. What does that mean? That means we don't know the right one to do, period. Anytime there's more than one operation described for one condition, that means we don't really understand the right thing to do, because we're all ethical surgeons. I promise you that as much, okay? We're all ethical surgeons. If we knew the right thing to do every time, that's what we would do. So that's one of the problems with this. We really don't know yet. And the controlled, randomized study is going to be probably impossible to do.
Yes.
Yeah.
Let me just rephrase that so they can.
Go ahead.
So you say that you operate on 50% of the athletes that come to see you for sports hernia, and they're kind of expecting to have the surgery. What do you do with the other 50% that don't?
You have to kind of redefine the patients, all the patients that I see, okay? The high-level athlete, college athlete, pro athlete, high-level high school athlete, I would say probably 75 to 80% of those people I will operate on. So that leaves about 25. The weekend warrior, only about 10% I'll operate on those. So that's where the number 50% of all the patients I see. For the weekend warrior, they think that they're the next whatever. A lot of them come to me now without having seen an orthopedic or sports physician for a proper workup. So automatically they go to see them. That's number one. Two, they've done physical therapy. Well, what physical therapy you've done? Well, I looked up some things online and I've done a little exercise. I said, You're going for 6 weeks of organized physical therapy. You're going to see the orthopedic surgeon. Most likely you're going to get better. Most likely you're going to get better. And most of them do. And most of them I don't see ever again. Every once in a while I will tell them, if you're not better, you come back and talk to me again. We'll repeat this. We'll repeat what's going on. We'll repeat the ultrasound. Sometimes the ultrasound. Weekend warriors almost never have abnormal ultrasounds. Almost never. I'll repeat it just to make sure. If they continue to have the pain, however, with a good workup, good physical therapy, I'll almost leave it up to them. You want me to explore your groin? I'll do it. Okay. Those results are not as good or as predictable as the real athlete. The real athlete that doesn't have it, there's almost always something else going on. It's fairly obvious too. It becomes fairly obvious. Whether this new business of FAI, whether the labral tear, whether, it becomes more obvious. And I have seen a couple of college athletes where the ultrasound changed in front of me within 6 to 8 weeks. That's okay, well, we'll operate on you. But the group that's the most difficult is the real athlete, negative workup by me, yes, no, something found orthopedic, physical therapy, and now they still have pain. I'll talk with them again in the same way. Here's what we could do. We can give it a shot. You'd never use the operating room, never. No matter how safe or easy an operation is, I promise you, if you go for the wrong reason, it'll be a disaster. Okay, but then we have to have a serious discussion as to whether they want to give it a shot. Most of them end up not going. Once in a while, I will take them to the operating room to explore their groin.
Okay, I'm going to pitch a question Dr. Swan's way a little bit. Stress fractures. In the literature, there's an association between those who have had 2 or more stress fractures and a decrease in bone mineral density. At what point do you consider further workup, blood work, DEXA scan, for a high school or a collegiate athlete?
So if they fit the profile that you're worried about, which is typically female, often runner, with 2 or more stress fractures, a workup typically will ensue. I think our threshold for working these up has gotten a lot lower very recently. In terms of bone density scans, we've started to understand that they actually can have abnormalities when we compare their Z-scores, which is not what we're using in the older osteoporotic population. We use the T-scores. So there's more and more literature, including Kate Ackerman's, which is really sort of leading the charge here. So that's one thing to consider, bone density. And that makes us all feel better that we actually are doing more than just making them rest. Because a lot of times that's what the athlete feels. You need to rest, you have a stress fracture. One season goes away, the next season goes away, they try and get back out there. Maybe they start developing some new pains. What else are we doing other than rest? We try therapy, but really what they need at this point is a workup. So the two stress fractures would definitely be a reason to consider that. And then in addition, what else do we need to do? What labs do we need to work up? We need to investigate a little further, dig a little deeper about their medications, oral contraceptives, and then what do you need to modify there? So I don't think we have the full answer in terms of which the whole lab panel. There are some who support just throwing it out there and checking all of their minerals, their elements, okay, their vitamin D levels. We know a lot of people have vitamin D deficiency. Where does that land us here? I don't think we have all those answers. But certainly starting with a bone density scan is important. If that's low, then this is not normal bone that's getting a stress fracture.
Yeah, I think all of us are seeing problem stress fractures, and just anecdotally, I had like 2 girls in the last 4 years with multiple lower extremity stress fractures in high school, and both were good enough to go on and compete in college. And they had no training errors, good diet, the whole thing, just kept getting stress fractures. So we did that whole, did the workup and bone density and blood work, and both of them were ultimately diagnosed with polycystic ovary disease by their gynecologist. So I think I'm not saying that that's the cause of the stress fractures, but I'm saying when you're seeing and as Dr. Swan just said, it's mostly the females that we struggle with. You do have to consider that there may be something else going on when you just, because we know how to fix all the training problems, good shoes, gradual ramp up. We try everything, and sometimes you just can't win. And those are the patients that I do think really warrant a workup, because maybe there's another underlying cause. We don't understand this as well as we should.
Phil,
A question in the back? Oh, I'm sorry.
well, I did want to mention the menstrual cycle is a difficult question to ask or conversation to have with a teenage athlete and the parent in the room. And maybe there's some privacy issues that the parent and the daughter are not talking about, or maybe it's uncomfortable as a strange doctor in the room talking to the daughter about this. But you have to have that conversation. And sometimes the parent thinks it's normal to have an abnormal menstrual cycle because they're working out hard. That's normal, right? No, it's not normal. We've demonstrated that. So maybe people used to think it was normal, but we're learning it's not.
I'll rephrase the question for the people at home. So if you have a 16-year-old girl who just got her menstrual cycle, at what point do you scrutinize it a little closer? Meaning if she has less than 10 or 12 periods in a year, at what point are we getting really concerned over their abnormal menses or delayed menses?
If you had a 16-year-old who just had menarche, I would be concerned right off the bat. That's a little old for menarche, but you have to, like Dr. Swan said, you have to have that discussion. I would have that discussion. If you're afraid of the parents in the room, you'd have them step out when you do the intimate exam, if you will. and then ask them when the parent's out of the way and find out what the real story is. But a 16-year-old with menarche, something's wrong. But usually, not always, but usually.
Yeah, especially in the presence of a stress fracture or a second stress fracture, then that's very concerning.
I think as some of the literature says, for each year beyond the age of 12 that their menarche is delayed, their incidence of stress fracture dramatically increases. So it becomes a problem if you have a 15-year-old athlete that hasn't gotten it, or a 16-year-old athlete that hasn't gotten it. That's a big red flag.
Right. The other issue is from long-term life counseling for women. So, it's not uncommon for an elite level gymnast to not begin menstrual cycles until they're done with their collegiate or Olympic career, which could put them well into their 20s. And there's evidence that says that most of them are going to have clinically significant osteoporosis as adult women. So even if they're not presenting with injuries, it's part of your pre-participation physical history, and if they're abnormal, it probably warrants a little bit of counseling in terms of later on in life.
I believe the spokesperson for Fosamax, or one of the bone medications, was Olga Corbett, and at the age of 30 had a DEXA scan of an 80-year-old lady. So it's something, even though we think it's all, they're young and athletic and it's no big deal not to get their menses, it does impact their lifetime bone health. Other questions? Yep.
We were speaking about further evaluating, further testing with two stress fractures, say, correct? Do you only go with those extended evaluations if they've had stress fractures repeatedly twice, or what about the young lady who's got technically that stress reaction that lasts an entire season that she can't get rid of, but there's no stress fracture after having been evaluated? It's being diagnosed as that stress reaction, but it's still lingering that entire season long. Do you consider going with the further evaluations at that point, or is that only due to, do you only get that far after she's had or anybody's had that two stress fracture?
I think that's a very good question, and we run into that issue a fair share. If we call it shin splints or that sort of vocabulary, we see it all the time, and we don't have exact answers to what do you do with those folks, because is it a stress reaction? It is from overuse, right? So, and we're not getting them better with the typical methods. So, I wouldn't say we have a protocol for that, but yes, we do sometimes work those patients up to see what can we find here, radiographically, density-wise, lab-wise. Unfortunately, I feel like you often don't get the answer. We're still learning.
It tends to be, I agree with Dr. Swan, it's just it tends to be low yield. I mean, we all have those patients, and I mean, if they're willing to keep on coming to see you for a year without getting better, you feel like you got to do something. You do all this lab work, and hopefully you'll find something. But I mean, more often than not, everything's negative. It's a very challenging patient to take care of. I think if we keep, maybe if everybody keeps digging, we'll ultimately find what the problem is.
All right, one more question in the back, and then, yes. So to rephrase the question from the audience is, when dealing with a middle school athlete, a younger aged athlete who's involved in a lot of activity, track, cross country, and may or may not have normal menses or having other issues, how concerned are we, or should we be getting with those middle school athletes?
I think for the most part it goes back to have they had a stress fracture yet? If they're there and they're that young in your office with a stress fracture, that's concerning. It's concerning for now. It's concerning for their career going forward. So I think it's good to start that conversation. Maybe their menstrual cycle is sort of just ramping up, so it's not regular yet. and it will get there. But if you start having them pay attention to it, that this does matter. And I think this conversation is in some ways a little bit like the concussion conversation we were having 10 or 15 years ago, that we're talking about it a little bit more. There's some more studies coming out of Boston that are making us think about this a little more and not accept what we thought was just part of the sort of endurance workout routine. So going forward, if people are thinking about it, talking about it, what is normal for that middle school endurance runner? Have we defined that? Is it okay to delay your menstrual cycle a little bit because you are working out very strenuously? It seems like it probably is not, but I think as we do start discussing it more, understanding it more, having it part of the conversation, we could answer that question better.
I think anytime you're dealing with hormones in anything, any endocrinologic problem, most of these kids have normal menarche and normal cycles. Most of them. How come these kids with these athletes are not having it? There's something wrong. Okay, there's something related. Okay, that was a very good analogy with the concussions. Most of them are normal. When you talk, when I see the women, I always ask them about female athlete triad and how is that related somehow, only because I guess it's just part of a full history and physical. But normal is normal. You should have menarche. Menarche is kind of coming down in the United States over the past 20, 30 years. It used to be said 14. Now it's 12. I mean, 12 is 12, 13. If you're not having menstrual cycles by 14, something's potentially could be wrong. I'm not saying it is wrong. There's probably somebody out there who had their menarche at 15 and has 7 kids. But but if you're not having a normal menstrual cycle, especially by the age of 16, and then you go throw in athletics in there, something's wrong. Something's wrong.
We have as part of a supplement on the compendium, we have a screening tool, and we also have a copy of the blood workup that Kate Ackerman from up at Boston and our docs have kind of incorporated as well, just for you as a reference point. I think we're going to conclude at this point, but I just want to make one announcement, where I know some people have been waiting for this for a while, but University Orthopaedics, as of June 1st, will be a provider for Horizon. So that comes as some welcome news, as
not for us.
Many of our
for them.
Of our people in New Jersey are customers of Horizon.
Years we're at.
So I want to thank everybody for their attendance, for their attentiveness, and for supporting University Orthopaedics. Please go online, complete the course evaluation, and just remember, we'll get the certificates to you within a timely fashion, the best we can. And thank you very much. Oh,